today I've been asked to prepare a POW on what stops a fracture from healing. Fracture healing is a set of complex events that aims to return the bone to its pre-fracture condition. The majority of fractures heal by secondary intention, which involves 5 overlapping steps. These are hematoma formation, inflammation, soft callus, hard callus, and then remodelling. This type of bone healing occurs when there is relative stability, so a small amount of movement at the fracture site. In contrast, primary bone healing occurs when there is absolute stability of the fracture, typically achieved by internal fixation. The mechanism in primary fracture healing is often referred to as cutting cones. So this is when tunnelling osteoclasts traverse the fracture site and are followed by osteoblasts that directly lay down new bone. There are over 1 million fractures that occur each year in England alone, and around 5% of these are thought to encounter problems in the fracture healing process. So it's important that we understand the factors that negatively impact fracture healing. There are 3 main complications of fracture healing that we hope to avoid. These are malunion, delayed union, and non-union. Malunion is the healing of bones in an abnormal position. Delayed union is the failure of the fracture to heal within the expected time for that fracture type and site. And non-union is when the union is delayed but also shows no features of ongoing healing. There are a number of factors which can negatively impact fracture healing. I've split these into 3 main categories. The first category contains variables that relate to the fracture itself. These are termed injury variables, and there's often very little we can do about them. They include all aspects of the injury, including the fracture site, pattern, damage to the surrounding structures, and whether there's likely contamination or infection at the site. All of these factors can be looked at individually and can contribute to the likelihood of successful or unsuccessful union. For instance, if there's been a significant disruption to the blood supply to the fracture site, there is of course an increased risk of non-union. And if infection or contamination is introduced to the fracture site, there is again an increased risk of fracture healing complication. The second set of factors which could hinder fracture healing are related to treatment. For example, if a fracture is improperly reduced, the bone ends may not meet correctly and the patient could be at risk of a malunion or non-union. Similarly, if a fracture is reduced but not properly immobilised, then again the patient is at risk of these fracture healing complications. Problems with treatment may not occur because of the treatment itself, but possibly due to patient compliance. And if a patient is non-complying with weight bearing or functional instructions, then they are at increased risk of complication. The last category involves patient factors, and this is the section that I'll focus on a little more. First of all, we'll have a look at comorbidities which can impact on fracture healing. First of all is diabetes. This can affect the repair and remodelling of bone. Studies have reported significantly higher incidence of delayed and non-union in diabetic patients compared to those who are non-diabetic. So tight blood sugar control is therefore important to reduce this risk. Anemia has also been linked to impaired fracture healing. This is likely due to the impaired delivery of oxygen to the fracture site. However, some studies have shown that so long as the patient is normal volemic, that the impairment of healing may be minimal, so fluid resus appears to be more important than blood transfusion in the early healing process. But correction of anemia is of course important for fracture healing. Malnutrition is another significant predictor of poor outcome when it comes to fractures. As high as 84% of patients with a non-union were found to have metabolic issues, with around 66% of these having vitamin D deficiency. Protein malnourishment, typically measured as albumin levels, decreases callus strength and increases the risk of fracture healing complication. Low albumin levels are also predictive of increased length of hospital stay and in-hospital mortality following fracture. One group in particular to be aware of is those who have had gastric bypass surgery, as they are more likely to have vitamin D and calcium deficiency, so supplementation may be required. There's also a possible link with peripheral vascular disease, hypothyroidism and HIV, but these links are less well established. Medications can also contribute to the inhibition of fracture healing. NSAIDs are commonly used analgesics that work through inhibiting cyclooxygenase. Cyclooxygenase, also termed COX, is thought to promote fracture healing by causing mesenchymal stem cells to differentiate into osteoblasts. So inhibiting COX is detrimental to fracture healing. NSAIDs should therefore be used with caution in those with fractures. It's also known that those in long-term corticosteroid therapy are at increased risk of fracture due to increased risk of osteoporosis. However, it's also been proven that corticosteroid therapy can be detrimental to fracture healing itself. Unfortunately, steroid treatment is often essential for many patients, so little can be done to modify this, but it is helpful to keep in mind that these patients may experience a prolonged healing time. Antibiotics are another medication that are frequently prescribed in trauma for the treatment of open fractures and prophylaxis in surgical procedures. However, animal studies have indicated that high-dose antibiotics, particularly quinolones, are toxic to chondrocytes, so can inhibit fracture healing in the early stages. These antibiotics should therefore be used with care. There are two final factors that I'll mention. Firstly, advancing age. So as we age, our fracture healing ability becomes poorer, and so the elderly are at increased risk of complication. And finally, but perhaps one of the most important patient factors, is smoking. So smokers have been proven to have an increased rate of fracture healing complications, specifically non-union and infection. Whether it's the nicotine or the other components of cigarettes is unclear, but the balance of evidence indicates that a clear inhibition of healing occurs in patients that are smokers, and therefore they must be advised to stop smoking as soon as they attend with a fracture. So that concludes my brief overview on the factors which can inhibit successful fracture healing. Just to recap, there are three main healing complications. These are malunion, delayed union, and non-union. Appropriate fracture management is the most important step to aid good fracture healing. When at all possible, try to avoid troublesome medications. These include NSAIDs and quinolones. We should consider optimising comorbidities, so ensuring tight glucose control in diabetics, improving nutrition if the patient is malnourished, and correcting anemia if found. We should also be encouraging all of our patients who are smokers to quit smoking and inform them of the risks that smoking may have on fracture healing. And that's me. Thank you.